Hello everybody, this is Lorenzo Costantini from Italy. I'm here to share with you a 20-minute trip from ECG to the EP lab, talking about Brugada syndrome. You might be wondering why we have to talk about that. Well, I'm sure that if you don't know yet the end of the story, you're gonna be surprised. During my training, I spent a couple of years in Barcelona, and I had the privilege to enjoy a lot of talks like this by my mentor, Josep Brugada. These talks used to share with me a lot of stories, free tips and tricks about Barcelona Football Club, Brugada syndrome, and electrophysiology in general. In this lecture, I would like to share a few of these concepts with you. Thank you so much for inviting me here. It's a pleasure. Current guidelines for the management of patients with ventricular arrhythmias and the prevention of sudden cardiac death define this entity as an inherited primary arrhythmia syndrome. The diagnosis of Brugada syndrome is based on a typical ECG pattern occurring either spontaneously or after provocative drug tests with intravenous administration of sodium channel blockers. The presence of all other known causes of ST segment elevation in right precordial leads, known as phenocopies, should be excluded before making the diagnosis of Brugada syndrome. Age and sex-related penetrance, incomplete penetrance, and variable expressivity are all hallmarks of this cardiac entity. Nowadays, it's difficult to discern the true burden of Brugada syndrome due to the unknown real prevalence of asymptomatic patients and the dynamic variability of ECG pattern. Nonetheless, the prevalence of Brugada syndrome is believed to range from 1 in 5,000 to 1 in 2,000 individuals. The incidence of Brugada syndrome pattern on ECG has ranged from 0.12% to 0.8% in several studies. It has been considered responsible from 4 to 12% of all sudden deaths and up to 20% of sudden deaths in patients with structurally normal hearts, and is 8 to 10 times more prevalent in men than in women. Following the original description of Brugada syndrome, there was much confusion about its ECG characteristic and diagnostic criteria. To clarify these ambiguities, an expert consensus document was published in 2012, establishing two descriptive ECG abnormalities for Brugada syndrome. The type 1, the code type, the one we are seeing in the slide, is the only diagnostic pattern for Brugada syndrome. It is characterized by an ST segment elevation of 2 millimeters or more in one or more right precordial lead. The descending ST segment crosses the isoelectric line, and this is generally followed by a negative and symmetric T wave. The Saddleback type 2, is only suggestive of Brugada syndrome. It is characterized by an ST segment elevation of 0.5 millimeters or more in one or more right precordial lead, followed by a convex ST. Their first wave may or may not overlap the J point, but it has a slow downward slope. The ST segment is followed by a positive T wave in V2 and is of variable morphology in V1. To facilitate the differentiation of type 2 ECGs highly indicative of Brugada syndrome from other Brugada-like patterns such as athletes, pectus excavatum, and arrhythmogenic cardiomyopathy, several additional criteria have been suggested. One of these criteria uses the triangle formed by the ascending and the descending branch of our first wave. Frequent variation in the ECG patterns can occur within a single patient, including the absence of classic ECG pattern on a given day, defining the concept of concealed Brugada syndrome. And here we have the mystery of Brugada. I would like to say you something more about Brugada ECG. This ECG is from a patient that was referred to us for a syncope during recovering from sport. It smells. Well, it seems to be an incomplete right bundle branch block, but if you focus on QRS duration in the peripheral leads, you can see that QRS is very narrow. Well, I'm sure you all already know the end of the story. Talking about dynamic ECG pattern, 12 leads alter ECG can be a powerful tool in detecting a dynamic type 1 ECG. In our group, if there's the suspicion of Brugada syndrome, before making any other test, we perform an alter ECG, placing all 6 precordial leads of the alter in V1 and V2 position, in the second, third, and fourth intercostal space, respectively, in order to optimize the sensitivity of the technique, increasing the probability to sample a spontaneous type 1 ECG. The next step is the sodium channel blocking test. When there's a clinical suspicion of the disease without a spontaneous type 1 ECG pattern, for instance, as a subject presenting with syncope, agonal respiration, aborted sudden death, or only a family history of Brugada syndrome, or a suggestive but not diagnostic ECG, a pharmacological test with a sodium channel blocking agent shall be performed to unmask the disease. The test must be performed under continuous ECG monitoring, and it is considered positive when a type 1 ECG pattern is identified during the infusion. Widening of the QRS to more than 130% over the baseline value of the presence of frequent ventricular premature beats or more complex ventricular arrhythmias should be a warning sign to stop administration. Intravenous Ahmalin and flecainide are the most widely used pharmacological tests. In some countries, there are no class 1 intravenous antiarrhythmic drugs available, and oral doses of flecainide or propafenone are used instead. Continuous monitoring should be maintained until the ECG reverts to the baseline, and it is important to remark that, like all the tests we perform, nearly 25% of drug-induced tests might be false negative, and this should be taken into consideration when, for instance, a patient experiencing aborted sudden cardiac death with a suspect ECG as a negative flecainide test. Flecainide test has a failure rate more important than Ahmalin test. Ahmalin test is more sensitive by our center experience. A repeated drug test using Ahmalin should be considered so whenever possible. Structurally normal heart, who knows? Although Brugada syndrome is commonly considered as a channelopathy, evidence has revealed structural derangement of the right ventricle. Using cardiac MRI, Brugada syndrome patients were found to have right ventricular motion abnormalities compared with normal individuals. Although late gadolinium enhancement was not detected in cardiac MRI, histological evidence of substantial fibrosis in the ERV of TU epicardium corresponding to a low expression of connexin 43 was found in the hearts of Brugada syndrome individuals. Of course, malfunction of ionic channels still play a key role in the current view of pathophysiology of Brugada syndrome, but a broader vision nowadays is mandatory because often ionic channels and connexin play together to keep the normal function of the cardiac cells, but this is another story. Let's talk about increased sudden cardiac death risk. That's the heart of Brugada syndrome. There are two major pathophysiologic models explaining the electric abnormality in Brugada syndrome. namely the repolarization and the depolarization models. Despite their differences, both models agree that the major region of pathology is right ventricular outflow tract. In both the pathophysiological models, transmural or intercellular heterogeneity or membrane potential create in a given moment of cardiac action potential an electric gradient that can trigger functional reentry. In the same way, heterogeneity in impedance, conduction, or presence of fibrosis can contribute to worsen the situation and to harm the electrical bond. Let's talk about sudden cardiac death stratification of risk. Accurate stratification of risk of sudden cardiac death is a major challenge in the clinical management of Brugada syndrome patients. Subjects presenting a drug-induced Brugada ECG and completely free of symptoms can be classified as low-risk patients. Subjects showing a fever-induced type 1 ECG without any symptom can be classified as intermediate risk patient. Subjects showing a spontaneous type 1 ECG or aborted sudden cardiac death or syncopal events or EPS inducibility maybe can be classified as high-risk patients. And the management is very different from one group to the other one. In low-risk patients, no clear-cut recommendation has been defined, and low-risk patients are substantially asymptomatic patients with drug-induced pattern. Ambiguity surrounding the severity of the disease in this group and the value of electrophysiological study inducibility to identify high-risk patients exacerbate the difficulty in management of the asymptomatic patients. The reported annual rate of asymptomatic Brugada syndrome events has decreased over time. This change probably reflects an inherent early referral bias when particularly severe forms of the disease were more likely to be diagnosed. Even among more recent studies, the rate of arrhythmic events in asymptomatic Brugada syndrome patients is not negligible, 0.5 to 1.2 annual incidence, so the risk is still present. Appropriate assessment to rule out purely vasovagal or neuromediate syncope is also recommended in subjects that have no clear events, because the management between asymptomatic patients and symptomatic patients change a lot. Women with Brugada syndrome typically show more benign clinical features with a lower percentage of type 1 Brugada syndrome ECG and a lower prevalence of symptoms. However, events still occur in women and no appropriate sex-specific risk predictor exists. Let's talk about the intermediate risk group. An important risk factor is a fever-induced type 1 ECG, because this feature reflects a temperature-induced impairment of cellular electrophysiology. ECG of Brugada syndrome, the type 1 ECG reflects an impairment of cellular electrophysiology. Never forget this. This is the heart of Brugada syndrome. And this potentially lead to electrical instability and ventricular arrhythmias. Therefore, a more strict clinical follow-up and eventually, I recommend this, ILR implantation are desirable in this group of patients. In addition, I always instruct my patient to take paracetamol in case of fever, and if unable to achieve a temperature of less than 37.5 degrees Celsius, I recommend them to go to the emergency department for monitoring. That's the key point. Emergency department for monitoring with fever in patients with the type 1 ECG induced by fever, because you never know the magnitude of electrical instability and the magnitude or impairment of cellular electrophysiology in this class of patients. It's very, very important. About high-risk patients, that are patients showing a spontaneous type 1 ECG, and for my group, spontaneous type 1 ECG if asymptomatic with the EPS inducibility, or patient who experienced an aborted sudden cardiac death, or patient that with the spontaneous type 1 ECG or induced type 1 ECG and syncope. So symptomatic patient go to ICD implantation. They have to be protected. So ICG implantation, strict clinical follow-up, and avoid fever and Brugada drugs. Syncope is an indisputable risk factor and recognized by all studies, and most of them agree that the presence of syncope in combination with a spontaneous type 1 ECG pattern is a robust marker of poor prognosis during follow-up. Controversial evidence suggests the symptomatic patient and more easily induce arrhythmias during an electrophysiological studies, but this is still controversial. The expert consensus document and the current guidelines for prevention of sudden death neither encourage nor discourage electrophysiological study for Brugada syndrome risk stratification, but simply state that an implantable cardioverter defibrillator may be considered in cases of inducible ventricular arrhythmias. Barcelona Group has traditionally used EPS for the risk stratification in asymptomatic patients with a spontaneous Brugada syndrome type 1 ECG, as I said before. And this is supported by several large perspective registries. Also, a ventricular refractory period of less than 200 milliseconds has also been proposed as a predictor of adverse events in Brugada syndrome. And now let's talk about the worst category, the patients that are symptomatic, implant an ICD, you avoid fever, you avoid Brugada drugs, you follow up them very strictly, and they still have events. Multiple ICD shocks, arrhythmic storm, with the very, very difficult end patient. We are still two options for this patient, quinidine and ablation. Okay, radiofrequency ablation has risen as a promising therapeutic option for Brugada syndrome in the past decade. Studies have demonstrated that in addition to abnormally low voltage, prolonged duration, and fractionated electrograms, histologic and molecular changes, including inflammation, fibrosis, and low expression of connexin 43, have also been found at the anterior right ventricular outflow tract epicardium. These findings have established the foundation of ablating the substrate as a feasible treatment for the Brugada syndrome. The current consensus recommendation considers radiofrequency ablation as a reasonable therapy for Brugada syndrome patients with arrhythmic storm or repeated and appropriate ICD shocks, because we have to remember when a Brugada patient has an ICD shock, we have to check if the shock is appropriate or not, because the Brugada pattern can jam the ICD itself. Just remember, and this is another story, but is subcutaneous ICD in Brugada patient do it better. With the progress made in recent years, there is hope the radiofrequency ablation might even offer a cure for these selected patients with a very severe form of Brugada syndrome. A cure for the most severe disease. Despite early attempts for ablation, beginning with the endocardial approaches, endocardial ablation of arrhythmogenic PVC, and endocardial mapping with ablation of late activation zone, later studies have shown that most of the electrophysiological substrates locate at the right ventricular outflow tract epicardium. And thus, epicardial ablation has become a more accepted approach due to its improved efficacy in eliminating the arrhythmogenic substrates. So, the procedure is complex. You have to select the patient candidates to this kind of procedure. And the target of the procedure is ambitious. ECG normalization and not arrhythmia reinducibility. It's very hard target for this kind of the procedure. Not only ablating PVC, you have most of the times you have to ablate the entire surface of RVOT. So selecting patients for this procedure is very important because the procedure itself is an hard procedure to perform with high rate of complications. Here you see the mapping with sodium channel blockade administration. When the sodium channel blockers are administered during mapping, this increases the resolution of the identification of arrhythmogenic substrate and consequently the efficacy of the procedure itself. Substrate ablation is associated with the ECG normalization, but you have to identify the substrate before, and you have to ablate it anteriorly. You have not to leave 1 gram of arrhythmogenic substrate, otherwise you won't reach the goal of the procedure. This observed correlation further suggests that improving the sensitivity of substrate identification is the key to improve ablation efficacy. So, 3-step procedures: identification of the substrate without sodium channel blocker, enhanced identification of the substrate with sodium channel blocker, and then ablation. Ablation of all the substrate. That's the key. And contextually, ECG check the normalization of the type 1 ECG pattern. So take home message. There's a quite long way between ECG and EP lab in Brugada syndrome. The complexity of Brugada syndrome continues to evolve. It's very fascinating disease, and therefore understanding the mechanism of this disease is imperative to provide better alternatives for treatment. Early detection and risk stratification are areas of major importance in the treatment of Brugada syndrome. And radiofrequency ablation of RVOT substrate has risen as a promising treatment modality for Brugada syndrome in selective, very high-risk patients, although larger scale and long-term follow-up studies are required to further determine its merit, okay? So, what's the take-home message? The same of the last year, the best is yet to come. And I hope that the best is coming soon and all the pandemic ends, and we can be all together again as last year, because memories are very important, and I appreciate a lot the memory I used to share with you, and I miss you a lot. Thank you very much for your attention, for inviting me, and for this 20 minutes walk through Brugada syndrome. Thank you.